Both of them are quite complex, so I think in order to get through them in any kind of detail, we might as well get started. So,
Great. Thank you.
so first one is what are our best recommended medications? So we're going to examine this case in some detail. So 57-year-old female was referred for evaluation of possible amyloidosis. She had noticed over the past 6 to 9 months that she had been more fatigued and was having to take naps every day in order to finish work. And she's a veterinarian, very busy veterinarian. She also had significant PND and orthopnea and had gained about 10 pounds, which for her was quite noticeable. Her appetite was okay, although she had a lot of nausea and abdominal distension as well. Her weight was 144 pounds, pulse 92, respiration 16, blood pressure was 84/50, and her O2 sat was 95. Initial exam showed quite significant jugular venous distension, several centimeters above normal. Decreased breath sounds about a third of the way up bilaterally. She did have a regular rhythm but was tachycardic and had a loud summation gallop. And she had a palpable liver edge and then trace lower extremity edema. Her echo from an outside facility showed EF was 45/50 with mild LVH. They attempted to do a cardiac MRI, but it was incomplete. But they did give her gadolinium, and it looked like there was diffuse gadolinium uptake in the outside MRI. So her other procedures included a cholecystectomy, a knee surgery, C-sections, a colonoscopy that was pretty unremarkable. She did have a left and right heart cath at the outside facility that showed no coronary disease. She did have high pulmonary artery pressures, and she actually had 2 thoracenteses in the past few months before being seen, both on the right side actually. Family history was unremarkable. Social history, she was a veterinarian, didn't smoke, drank just wine nightly, and exercised on a regular basis. Her medicines when I first saw her were lisinopril 2.5, Coreg 3.125, BID, aspirin, potassium, an inhaler, Lasix, 2 tablets twice a day, fish oil, and spironolactone 25 once a day. So there's her EKG. So do we have any speakers on the line, or only Eric?
We do have speakers, and we have Dr. Santos. I'm not sure who else is a speaker. Dr. Santos, would you like to look at our EKG?
Wow.
Yeah, so that may not be totally fair because she is an adult, but
yes, I work with small children. Yes. Well, of course, I can see the signs of the LVH that the echocardiogram has shown before, and that's the main thing, and then enlargement in the left atrial too. So that's the main things that I'm looking now. Sorry if I commit any mistake.
you didn't make.
I'm sorry.
You didn't make any mistakes. That's all correct. Except for I would say it is unfair to show you an adult EKG for older people problems.
You did a great job, Doctor.
That's right.
Great job. They're little adults, is what
Let me call a doctor.
Children are little adults, isn't that right?
A little adult, yeah. Yes,
well,
the T waves are inverted, of course. I suppose that because the H is the great sign. I'm sorry.
Yeah, so there are those findings, but the other thing, which again is not going to be very apparent in a child EKG, but the voltages in the limb leads are pretty low, and you can't see all the detail there, but certainly all the limb leads are quite low, so that especially in somebody who has LVH on an echo and then has low voltages on an EKG, that's sort of a classic board type question for amyloidosis. So you would be pretty suspicious about amyloid based on this EKG. So other labs include basically normal electrolytes. Cholesterol was fairly unremarkable, a little elevated, LDL 128. Her troponin was normal at this moment. Her BNP was 232. Normal is 100 or less. She did have serum protein electrophoresis, which was fairly unremarkable, including no monoclonal spike. And then she had a 24-hour urine, which did not reveal any significant proteinuria, and did not reveal a protein spike in her urine electrophoresis. So because the diagnosis of amyloid we were very suspicious of it based on the outside MRI, the EKG, and then the clinical presentation, we did do a right heart cath and a biopsy. Here are her right heart cath numbers. You can see her pulmonary pressures are pretty elevated. 56 over 26 was her PA pressure. Her mean pulmonary capillary wedge pressure was 30. Her systemic pressure was only 90 over 60. And then her mixed venous sat was acceptable at 70, but her FIC cardiac index was 1.76, which is, pretty low. Normal is 2.5 or so, and this is pretty reduced. So, Eric, what do you think about those hemodynamics?
Well, it looks like left ventricular diastolic pressure is going to be elevated because of the mean pulmonary capillary wedge, and then there would be reactive pulmonary vascular hypertension. But then the right side is a little elevated too, so it must be translating backwards into the right atrium and causing a right atrial relaxation problem with big A wave. And then the fact that her cardiac output is markedly reduced, and we know she has, I think, a normal ejection fraction would make you think diastolic dysfunction. And the pulmonary vascular resistance isn't all that high compared with systemic vascular resistance. And so it certainly would be compatible with diastolic dysfunction of amyloid disease.
Sure. And I would say quite significant too. I mean, not it's hard to get your index, below 2 without a pretty severe impairment in diastolic filling in this case. So, okay. So what is the optimal therapy for this patient? So she was on a teeny tiny dose of lisinopril and a very teeny tiny dose of Coreg and some Lasix.
There are some clinical trials now being done with Entresto, a subitrol naproxen inhibitor plus an ARB for diastolic dysfunction. We don't have those results yet, but there is a big trial that's going on for that, so that might be consistent with the concept.
Yeah, so I don't know. This one's tough because, certainly she hasn't gotten on typical heart failure therapy for systolic heart failure. She's not able to tolerate that.
Of course, our big problem is going to be hypotension, and the fact that her blood pressure is so low, that's going to make it very difficult for all these medications. But she did have a sinus tachycardia, and I guess she's trying to compensate for her low stroke volume by increasing her heart rate. So disturbing her sinus tachycardia may actually create a problem in that heart rate times stroke volume equals cardiac output, and she can't increase her stroke volume.
Yeah, I don't know. This is tough. And then I think the other piece is that, you know, at some point you have to say, you know, she's sort of gone beyond medical therapy, and should you just be thinking about, in this case, you know, listing her for transplant, basically. Because if you're talking about an LVAD, for example, in somebody who has amyloid, that usually doesn't work out very well. So most people would say that if you think you need to do some advanced cardiac therapy, heart failure therapy, you're probably talking more about transplant in this situation. So do we think we need any other testing to help us decide these things?
Well, I'd like to see the results of the endomyocardial biopsy that you did.
Okay. So this probably pissed me off more than anything I've ever been involved in. But so we did a genetic screen for TTR amyloid, especially mutational TTR or familial, and that was actually negative. The biopsy initial read was negative for amyloid, including standard H&E staining, but also the electron microscopy. And I put in there the actual reading that they have. Mild cardiomyocyte hypertrophy and interstitial fibrosis, negative for amyloid. I just could not believe this result.
It's inconsistent with the MRI. The MRI, basically you get a quick light gadolinium flush that basically sort of occurs. You've got to start scanning early, and the MRI is pathognomonic. So they said they had trouble getting an MRI. I'm not sure if that was because of heart rate problems or patient motion or respiratory, whatever it was. But it should be pathognomonic.
So anyway, they read it as negative. I couldn't believe it. But so we did a TTR pyrophosphate scan, which is supposedly really good for detecting cardiac amyloidosis from TTR. And, you know, I'm not sure I totally believe that data right now, but we've done about, I don't know, maybe 15 to 20 of these scans, and some of them are reliable, I would say, but some of them I'm not so sure. But in her case, it was read as negative. So after all of those tests were done, she was seen, and she had been very careful about her sodium. She tried to be active but was not able to do much because she would get short of breath just going upstairs. She did have some orthopnea but denied any PND after we adjusted her diuretics. Her physical exam, when blood pressure was 80/46, pulse of 96, respirations of 18. She still had significant JVD. She had decreased breath sounds bilaterally, and she still had basically a summation gallop. She had really just trace edema.
Well, Dan, we built here sort of a little gestalt, a constellation of information, and I always take the liberty of, if one thing is inconsistent, I throw it out. And so the inconsistent thing I would find here is the Congo red stain of the sample. And so frequently you do get a sample that's negative because it's hit or miss when you're biopsying the heart. And so you don't know what island of myocardial tissue you got into when you did the endomyocardial biopsy.
Yeah. Yeah, this is a great point. I couldn't agree more. Everything about her presentation, the way her hemodynamics were, the way her symptoms were, pleural effusions, everything, EKG, all of it pointed directly at amyloid. And then we have a biopsy that was negative. So anyway, we felt like you can't make a diagnosis of amyloid without a biopsy of something. So you got to have a diagnosis pathologically. Because she was so sick, we did an SVO2 to sort of see where she would B, as far as possible listing for transplant, and she did a 15.7, which is pretty good for her considering, and she was able to go 8.5 minutes on a Naughton protocol. So at the time, the current medicines were aspirin, Lasix, 160 in the morning, 80 in the afternoon. The lisinopril had been held because of hypotension. She was on Zyrtec for what she thought were allergies, fish oil, and the spironolactone. Twice a day, actually, 50 twice a day. Her labs are listed below. They show cholesterol is still a little bit abnormal, and at this point, that LDL of 138 is probably too high for me. Then actually a repeat troponin, this is now about 2 months after initially being seen, her repeat troponin was now elevated, and her BNP was quite a bit higher than it had been. So previously it was in the 200s, and now it's in the 786. So it didn't seem like we were doing any better. So as you said, Eric, something didn't make sense, and the MRI was really convincing from the report anyway. So we repeated the MRI, and I tried to get the loops to run, and I couldn't do it. But here's a still frame of one of the images, and you can see the pleural effusions on both sides that are quite substantial. Her LVH is I would only consider it mild. But she still had basically normal systolic function on the MRI. And then this is one of the images, and you can see this rim of gadolinium uptake all, sort of throughout the entire endocardium or myocardium. And then this is the still frame of the gadolinium images. And so, Eric, I don't know if you want to comment on this.
Well, yeah, it's certainly don't see a lot of gadolinium in the right ventricle, which was where we biopsied. You probably biopsied the right ventricular apical septum. Is that what you think you biopsied?
Yeah, I'm sure they did.
Out there, and on that side, it doesn't look as much gadoliniumized as it does on the left ventricular side. So you probably got some of that tissue over there. So, but it does look like, I'm not sure what phase this was in terms of looking at gadolinium and what these images are, but certainly the other images did show that there's a lot of gadolinium in the myocardium. So the bottom line is it looks like a duck, flies like a duck, and quacks like a duck, waddles like a duck. Must be a duck, right?
Yeah, it must be. And I keep looking for the tail feathers, but, Anyway, so now what do we do? So she's still very symptomatic, but not bad enough to list for transplant. She has no blood pressure to work with. She has an MRI that's diffusely abnormal. And we are very suspicious of amyloid, but we haven't proven it yet. In terms of medicines, what would everybody do? Any thoughts? So I listed some possibilities there. Inotropic therapy is, in theory, is an option. But, that seems a little crazy since you have, basically a normal EF, but you did have a very reduced cardiac output. I do think that there is some evidence that, well, actually, if you go back 30 years ago, inotropic therapy is actually very well known for improving diastolic filling. So, you could make an argument that by giving a catecholamine in this setting, you would improve diastolic filling. There's plenty of animal and human data from 30 years ago that would say that. But, nobody actually does that. But nonetheless, that's out there. Continue the diuretics. Yeah, of course, we're going to continue those because she still has bilateral pleural effusions. What about, ACE, Coreg, and Entresto, any of those medicines? Would anybody try to do something there when you got a blood pressure of 80? We got no speakers? No
I don't
speakers on
think
the line?
I don't think anybody wants to use those drugs with a blood pressure of 80, and the ivabradine again decreasing the heart rate with heart rate times stroke volume being very important here might not be a good idea. I've not used midodrine. I don't think she has symptomatic orthostatic hypotension, but I've never used that for diastolic dysfunction. So you'll have to clue me in on that.
Well, so this is somebody who exists in the amyloid space knows all about midodrine because you have to use it too frequently. You have, these people have a lot of autonomic dysfunction and a lot of orthostasis. And so you got to give midodrine to sort of increase their vascular tone. And, I think that even though we haven't got a biopsy-proven amyloidosis, we've got everything that points in that direction. And so that's why I put out there about midodrine, because it can help bring the blood pressure up some in these people that have pretty significant autonomic dysfunction. And then ivabradine, the reason I tossed that out there is that, if you look at the guidelines, especially the European guidelines, they have ivabradine squarely in this spot, where if you have somebody who is resistant to typical medications and still very symptomatic, then they actually recommend starting ivabradine a lot earlier than we would do in the United States. That's for sure. But, maybe not in this setting with a patient with amyloid. So anyway, what I chose to do actually was to add midodrine to try to get her blood pressure up. And then I actually did try ivabradine because I thought she was persistently tachycardic. And I also think that there is some improvement in autonomic function with ivabradine. There was actually one study where they did a randomized study showing that in people with profound autonomic dysfunction, the people that took ivabradine actually had improvement in their general symptoms and hemodynamics. So I thought the combination of midodrine and ivabradine might be useful in this setting because I was sort of running out of options. So the next events, this story is not done yet, so I wanted to bring you guys into my struggles. So about 2 weeks after that last visit, she had a stroke, had an emergent catheter thrombolysis, and is actually recovering from the stroke. She does still have some residual. She did have, even though we had done an SPEP and a UPEP before that were negative, we repeated the serum light change, which this time were quite elevated. She underwent a bone marrow biopsy that revealed myeloma. No amyloid on the bone marrow biopsy, but they did report myeloma, plasmacytosis. And then I had asked the pathologist to review this case 3 other times formally, and on the 4th time that I asked him to do it, he went back to the EM on the original biopsy and said, okay, maybe there is some amyloid there. And I'm like, okay, whatever. Because there is a condition called light chain deposition disease where you can get all the appearance of typical amyloid, but you don't get stains or not positive for amyloid, the typical Congo red stain. So the way that you prove that is you do the staining with immunohistochemistry, and you see the light chains depositing in the tissue. So we did that a few days ago, and they haven't reported the result yet. But her PA pressures when we redid the biopsy were still elevated, actually quite elevated. PA pressures were 68/27. Pulmonary capillary wedge mean pressure was 27. Her index was still 1.3. and her mixed venous sat now is 51%. Last time it was 70, so we're kind of losing ground there. So I don't know if anybody has any comment about that.
Was that while she still had ivabradine on board? What was her heart rate when you did the cath?
Heart rate's been pretty consistently about between 80 and 90. And she actually seems to have, her blood pressure has been typically in the 95 to 100 range the last few weeks, and she's felt better on the midodrine and ivabradine, so I've continued it for now. So I think this is a really challenging story, and I'm not sure that we have anybody wanting to give me the answer to all of these challenges, but I think that this sort of highlights the difficulty that, you know, in terms of medical therapy that occurs in patients with amyloid. It's very challenging sometimes, and you know, you can't, you recognize that the patient has significant heart failure, but you're very limited in what you can do about it. So I don't know if anybody has a comment about that.
Well, I was going to ask you, did she have PAF? Is that why she had the stroke?
You know, we had no proof of that. We had no no previous history of AFib. There had been a monitor done once that didn't show that. You know, that was about 2 months ago. But you bring up a really good question. So she was on baby aspirin when she had a stroke, and the neurologist said, well, you know, that's it. We're not doing any other therapy. But I just couldn't believe it. You know, she was, now she has, you know, basically a diagnosis of myeloma and is going to get treated with chemotherapy. And that's a very high-risk group for a thrombotic event. So I started Xarelto on top of aspirin about a week ago, because even if I didn't have any proof of paroxysmal AFib, I still thought that her risk of a repeat thrombus was very high. So
might be around 80% chance of having a thrombus somewhere.
Yeah, and you know, we didn't find any particular evidence of it, but I don't know. I've had some really challenging patients with amyloid that have very difficult thrombus issues, and I think that when you have atrial dysfunction that happens frequently in amyloid patients, then they're very susceptible to atrial thrombi, even if they're in sinus rhythm.
Carrie, Carrie Linneman's come on. Carrie, can you talk? I think she's having trouble speaking.
Okay. Well, so I did want to point out that, you know, the ESC guidelines have ivabradine pretty early on in their guideline-directed therapy. Again, this is primarily for reduced ejection fraction. And so if your EF is 35 or less and you're tachycardic and still symptomatic, then that's an appropriate therapy. But, you know, how does that apply to this patient? I'm not really sure. I'm just showing you what the guideline says. Okay, so second case is also challenging. 47-year-old.
Hey, Dan, did you have any problem getting the ivabradine approved?
No, I really didn't. Yeah, because I didn't specifically say about the ejection fraction. I just said she had severe heart failure and was still symptomatic.
Great.
So, you know, it's always challenging, like both with ivabradine and Entresto. Sometimes it's just the wording that you use when you send in your prior authorization that
Hi,
makes
I don't know if you can hear me. This is Lauren Baltzari from Yale.
Yes.
Oh, good. Hi. I'm sorry, I signed in a little bit late, so I missed the first MRI that you showed, but I briefly saw the second one. But I was just going to comment that the lack of RV involvement with late gadolinium enhancement would point more towards AL than TTR, just based on the imaging. I think, right-sided involvement is seen in probably about a good number, about 70% of the AL cases, but the lack of it would kind of push you to think that it might not be TTR, that there was no RV involvement.
Oh, that's interesting. Yeah, I mean, I think that's what we're ultimately going to come down to, that you have to classify her as AL amyloid at this point, but
Right.
technically speaking, she's probably going to have light chain deposition disease because she did have elevated serum light chains.
Right.
And so I'm waiting on the immunofluorescence, but I think she would have to be lumped into the AL category at this point. So yeah, no, that's a key comment. Thank you. So next case is 47-year-old female, recently diagnosed breast cancer, who has already started chemotherapy, and she was sent to assess her cardiac status while she's receiving treatment. So she had probably been treated for at least a month when I first saw her. She reported being short of breath with walking even up to just 100 feet. She denied any PND or orthopnea. She did have some lower extremity edema, denied any palpitations, syncope, near syncope, or chest pain. Her cardiac-related history, she had been seen at a different institution, so we just had these listed as conditions. We didn't have any details about the evaluation, so I can't tell you about severity of things. But she had on her list of things aortic valve stenosis that was felt to be moderate to severe, pulmonary hypertension, mitral valve regurgitation, diabetes, asthma, Hodgkin's disease, COPD, and hypertension. This is her list of problems. Just to give you a little more detail, her past cancer history, she had stage 2A Hodgkin's lymphoma in 1989, treated with mantle radiation. She had relapse disease in 1992, treated with MOP ABVD. And then this year, she had stage 2A right-sided breast cancer with a 3-centimeter initial mass that was ER/PR positive and also HER2 positive. She had already undergone a total mastectomy and had 0 of 6 lymph nodes that were positive in March of 2006. So I don't know what everybody on the call is thinking, but with all of that history, this patient never even saw a cardiologist before having surgery and already starting chemo is really astonishing to me, but that's what it was. So the planned therapy was adjuvant chemo and HER2-directed therapy, which would include Taxol, trastuzumab for 1 year, pertuzumab or Perjeta for 8 cycles, and then Lupron. I'm not sure where the Lupron comes from, but that's what they were planning. The current meds, she was on Advair, aspirin, Synthroid, and omeprazole. Her physical exam was notable for a little obesity there, a blood pressure 110 over 58. O2 sat was normal. Her JVD was 4 centimeters above normal. She had bilateral carotid bruise, but no decrease in her carotid upstroke, and her lungs had basilar crackles. Cardiac exam had a regular rhythm, a normal apical impulse. She did have a 3 over 6 systolic ejection murmur at the right upper sternal border and had a loud S4. She had a decreased S2. Her pedal pulses were normal, and she did have some extremity edema in her ankles. Her labs were mostly okay. Electrolytes, etc., were all fine. Her cholesterol was notable for a LDL of 131. She had a negative troponin. Her BNP was in the normal range. Her thyroid hormone was adequately replaced, and her hemoglobin was 8.7. Her chest x-ray showed no infiltrates, a normal cardiac silhouette, and reported reduced volumes. And then there's her EKG. So does anybody want to comment on that?
Well, Dan, it looks like a sinus rhythm with the rate of about 75 or so, a little faster, 80. And there's a very prominent voltage in lead 1 that would be consistent with left ventricular hypertrophy, sometimes normal variant on a thin person, but she's an obese person, so it would not be a normal variant. And then she's got an axis of like minus 20, and then she's got some terminal conduction, probably delay. It looks like it's probably a little bit wide, maybe 0.09, so could be a terminal conduction delay of some slight right bundle type configuration. And then the ST and T wave changes are very nonspecific.
Okay. Yeah. No, I mean, I certainly agree with all that. Here's her echo, which I was able to get the images to go. So it sounds like we have some echo experts on the call. I don't know if anybody wants to chime in on their thoughts.
New caller today, Andreas, has called in from Argentina, and so we'd like to welcome Andreas. He's heading up our Argentina ICOS called ICOS AR, and he's attending today. He's self-muted right now, but we want to invite, well, just tell him hello.
Okay, sounds good.
So looks like
oops.
Getting feedback from Carrie because she's looped in, meaning
Yeah, sorry, I'm having technical difficulties
issues
here, but
I can hear you
I
really
do see the
well.
echo.
So,
And,
yeah. So what do you think about
obviously
that?
I have it on a small screen, but knowing a little bit of the history, looks like her RV is a little generous in size and going sort of clockwise in the peristernal long. Aortic root looks okay. Aortic valve is obviously heavily calcified. The left atrium appears to be a little bit enlarged, and the LV looks to be squeezing well, and the mitral valve in this view looks to be okay, maybe a little bit thickened.
Yeah, that's certainly all quite accurate. The other piece would be she does have some suggestion of LVH on the short axis there. You look, you see it's kind of a little beefy.
Definitely.
So here's some other pieces of the echo. Since you did so well on the last one, you want to chime in there on that, Carrie?
Sure. Obviously in the upper left-hand corner you see the view of the aortic valve. It's terribly calcified, but from my small screen that I'm viewing on my phone, it does look like it is opening pretty well. However, it does have a pretty significant gradient going through that aortic valve, so it is going to be probably hemodynamically significant stenosis.
Yeah, on the bottom there, the velocity, peak velocity was about 3 meters per second. And then I don't know if you can see the other screen up on the upper right. There is some aortic insufficiency. It's probably in the mild to moderate range. The image is partially cut off. You can also see some evidence of mitral regurgitation. I think that was felt to be mild to moderate. So the final conclusion was at least mild LVH, basically normal function, moderate to severe aortic stenosis, moderate mitral regurgitation, and those were the main findings.
I've had a very similar patient with Hodgkin's with pre-existing valvular disease who had a rocky course with breast cancer treatment, so this will be interesting.
Yeah. So okay. So at this point, you got an echo that tells you she has some existing problems, but nothing too severe. And then, what's our strategy to try to keep her stable while she's undergoing treatment? Does anybody have any thoughts on that? So do we need to do any other testing, for example?
Well, one thought about that is cardiac CT would tell us if she had radiation damage to her left anterior descending, which would be useful to know in terms of ongoing symptoms and what happens to her. We think that she may have radiation sclerosis of the aortic valve, and so could just as easily have LAD disease or coronary disease. So I would do a cardiac CT. It's pretty easy to do. Creatinine's normal, and just get her heart rate down a little bit.
Yeah, I mean, I think that's a key point, and I would wish that she could have come and gotten a CT in your office, because at Vanderbilt's office, I don't think we ever really get very reliable CTs, so I didn't actually do that, but that would be a good test. She had a Cath at an outside facility that did not show significant disease. She had mild diffuse luminal irregularities, basically. And in terms of medications, what strategy? Right now she's on nothing other than aspirin. So her blood pressure when I saw her was basically 120/70.
Yeah, I would think about using at least some potentially an ACE inhibitor and or a beta blocker like carvedilol for some cardioprotection if she's going to be starting on chemotherapy.
Yeah, I agree with that. The problem is in terms of using ACE and or beta blocker in this setting. Now she doesn't really have any systolic dysfunction, so that's not the that's not the primary motive for improving her cardiac status. But for example, if you just said, okay, she has aortic stenosis, that's her primary problem, then there wouldn't be necessarily any medication that would be indicated as far as improving her hemodynamics. If her blood pressure is 120/70 and she has moderate to severe aortic stenosis and normal LV function, then I don't know what medication you would use to try to keep that the same, except for probably a statin. So I don't know. It's a tough question, I think. I don't know. Anybody have any other thoughts about that? So
the statin stuff didn't pan out on aortic stenosis and progression of disease, thinking that it's an inflammatory disease and the statin drug would be anti-inflammatory, but the studies didn't work out, and it really didn't show any change or any difference. And actually, statins in coronary disease accelerate coronary calcification, and so you would think that it would accelerate aortic stenosis calcification.
Yeah, that's not what I recollect about the use of statins in this setting, but I acknowledge that what you just said is quite true. So then, but I do also agree that in somebody who's undergoing complex chemotherapy, and let's just say they didn't have aortic stenosis, would you want to give them, especially somebody like this who's a very high risk for cardiac issues, would you want to give them either an ACE or a COREG for cardioprotection? And the answer clearly is yes. I mean, I would agree with that. but I was a little nervous about giving a vasodilator in somebody that that had aortic stenosis, even though it wasn't that severe. It was still pretty substantial. So, and especially because, you know, people getting chemo, their blood pressure goes up and down depending on what's happening, and so I don't know. It's a tough call, and but I agree with Carrie in the sense that I would like to do something to improve her chances of getting through the whole treatment. So this is actually what I suggested, and I tossed this out here as one person's thought. I'm not sure that any of them are the right answer, or I don't know what the right answer is. But because, you know, her EF is normal and she has moderate to severe aortic stenosis, she has existing cardiac disease, but is not, you know, of the LV function variety at this point. I do think that having some careful assessment of whether there's a change in her volume status or myocardial status is what we need to do, and you can't do that by serial echoes. I mean, you couldn't do enough echoes to be able to tell that. So that's where I would argue that this is a patient that using BNP to help guide your treatment choices would be very helpful in this setting. I do think that she should try to increase her activity if possible, because she's extremely sedentary and doesn't do anything. And then she wasn't monitoring her blood pressure, weight, or pulse or anything for the last 10 years. So just getting her to do that would be helpful, I would imagine. And then in terms of cardiac symptoms, especially any evidence of worsening AS or developing LV dysfunction, you know, she clearly needs to be reevaluated very carefully. And then, as I mentioned, I was nervous about starting any vasoactive medicine, although I agree with Carrie also that I did start carvedilol at a low dose just to have something on board. And then, even though Eric sort of discounted this approach, I thought we probably should give her Lipitor to get her LDL below 100 or closer to 70, just because I think she is at significant risk for you know, coronary progression, etc. And then some other things to consider in these patients that have had mediastinal radiation. You know, this is that there are a lot of patients out there that are existing with a history of mediastinal radiation, and now they're becoming older adults, and they have all the typical older adult problems. And, you know, but any of those older adult problems are much more complex in the setting of mediastinal radiation. So these are just some suggested things that were, you know, considered, you know, practical screening tools for various cardiovascular diseases that may exist in cancer survivors. So certainly the lipid profile, the TSH, because she did have radiation to her neck and she was already profoundly hypothyroid. So, I mean, these patients all have thyroid dysfunction because of the prior radiation. Of course, measuring blood pressure and a history of physical, those are important things. And then echo in this setting is going to be critically important because of the valvular complex and combined valvular disease that this patient has. The other thing that I would add is obviously a carotid ultrasound. She had bilateral bruits and has already had tissue damage from neck irradiation, you know, based on the fact that her thyroid is kaput. So I think that a screening carotid ultrasound can be really important in these patients. And then, of course, biomarkers and EKGs have their place for sure.
So someday she's going to come to TAVR, so we got to keep that in mind. That
Yeah,
she'll be
so
at TAVR.
it's interesting. I just went to the ESC meeting in Rome, and I met Zaza there. I thought he might be on the webinar today, but he presented a case of a patient with metastatic breast cancer that got in the middle of some treatment and started to developing worsening cardiac symptoms, and ended up he had to appeal to his TAVR team 3 times to get him to do a TAVR in this patient, and finally they did, and she ended up completing her course of chemotherapy, for a year of Herceptin and whatever other treatment they were giving. But she survived all of that treatment really without event after she had her TAVR. So I think that it's a real option in this patient if I ever felt like she became symptomatic from her valve disease.
Perhaps her mitral gauge.
Yeah, Dan, I think that you're exactly right. That's what I'm having to do with my patient. She didn't have metastatic HER2-positive breast cancer, but has very advanced HER2, and she's had multiple heart failure admissions from her AS, and she actually already had a bioprosthetic, so she is actually being considered by our TAVR team right now so that we can get her stabilized so she can finish her treatment.
Yeah, that's great, and I think that this is a very complex decision making, because somewhere along the way you have to decide that the aortic stenosis is the limiting problem, and if you have aortic stenosis that is not a limiting problem, then it's moderate or something like that, then you don't want to withhold their therapy. You want them to get their cancer treatment, obviously, because that's the biggest problem at hand. But I don't know, it's complex. I'm sure that you've struggled greatly with the timing of things.
Yes, we have, especially because she's been in and out of the hospital a lot with her heart failure, so it's tough.
Yeah, and I think the typical TAVR team is going to say, you have to have, aortic velocity of greater than 4, and you have to have this size aorta, and this thing and that thing, and to put the equation of this patient needs chemotherapy into that whole calculus is not something that they're usually prepared to do.
Exactly.
So it's probably not bivalvular heart disease. It's probably just the aortic stenosis, and she's blowing off across her left atrium, across her mitral valve, and that'll probably improve at the point when she gets a TAVR, because the mitral valve didn't look all that bad. And so I would think that would be the case. And then she does look like she has a small annulus, and you have to worry about patient prosthesis mismatch in a large lady like this. And so certainly would have to have the right size annulus. And so there's a lot of consideration, but certainly she's not a candidate for immediate sternotomy at any time because of the radiation she's had and the difficulty in access and the medium sternotomy and the difficulty with right ventricular adhesion and all that stuff.
Absolutely, yeah. So, at this point we're kind of proceeding along. She seems to be doing okay with her current chemotherapy treatment. She is being a bit more active, and I did put her on some Lasix to try to manage her volume status a little bit better. But overall, I'm just sort of closely watching at this point. But I think that any time that the scale starts to tip towards the aortic stenosis is the limiting condition, then I would agree with what Carrie's doing, and to really try to push the TAVR team to consider all the options. So I appreciate. Yes.
Lenihan, it's Veronica talking.
Hey.
May I ask you a basic question, please?
Sure.
It's for all the group. So even in a symptomatic young person with later after treatment of a chronic disease or radiation therapy so hard as this, what's the best test that you recommend in an asymptomatic system to check the coronary arteries? For a young adult, asymptomatic person, only as a prevention of something.
Yeah, I think I would do the first step would be, careful history and physical. I still think that is really the most important piece because, if you examine that patient, even if they're asymptomatic and you hear a systolic murmur, it's gonna make you really want to do an echo in that case. But also, I am a firm believer in BNP or N-terminal pro-BNP for screening for LV dysfunction, and then of course the lipid profile, and then TSH or other thyroid tests, because those patients frequently have thyroid issues. So those would be the basic things that I would do in an asymptomatic patient. So good history and physical, lipid profile, BNP, TSH, and then if you find anything on physical that tips you off that you have a systolic murmur that you need to address, then you get an echo. If you have a carotid bruit, then do a carotid ultrasound. In terms of one of the things that Eric talks about frequently, which I actually really agree with, is just we don't have a good system here in Nashville. But I think in terms of overall basic screening tests for severe disease, that a CT of your chest is, CT angio of the chest is going to cover the most bases in one particular test. So I don't know, Eric, if you want to comment on that, but I would agree that that's probably the best overall test, but we don't have a lot of data that says that that's the right screening test to do.
Okay.
We're getting better at that in terms of symptomatic people, and the Scottish continuation of the Scottish Heart trial showed that standard of care, which is stress testing, stress echo, stress SPECT scan, compared with CT plus standard of care, showed that if you did the CT and followed patients for a mean of 20 months, that you had a 50% reduction of fatal and non-fatal heart attacks. That's huge. That's a home run. And so CT is certainly getting more validity in terms of being able to separate patients into these pigeonholes where you've got normal coronaries, you've got minimal focal calcification, doesn't mean much. You've got intermediate findings. You've got rich lipid plaques, which is a 125.83 by CPT code, and you've got a dense coronary calcification, which actually has low risk in terms of coronary calcification. And so all these different findings, and so then you can pursue which one's important and which one's not important. If you have a negative test, you have a 15-year warranty of not having coronary artery disease. So that's a pretty good thing. So we're actually using it, looking at people who are high-stress individuals. And so we look at the SOCOM, CENTCOM, at the military, policemen, firemen, who have been shown by numerous studies that we had increased risk of having heart disease because of shift work and sleep deprivation and so forth. So we found it to be a good screening test, and we got it for reduced price of $329 total, and so that makes it convenient for patients. It's a 10-minute test. We can use ivabradine now, and we use ivabradine basically 2 hours before the test, and we're able to get the heart rate down. So instead of having to use a beta blocker for 3 days, so that also works out pretty good. So it's a wonderful screening test.
Super. I really appreciate everybody getting on the call today, and we love hearing from all over the world and our best friends from all these different places. We want you to keep joining in. I would remind you that we, of course, have our major yearly meeting at the end of September in Vancouver. I will also tell you that we have almost 250 registrants right now. This will be the highest attended conference so far, and the other piece is that make sure you keep in mind that I think late September next year it'll be in London, and Dr. Lyon is going to announce this officially soon. So So we're excited about these options, and definitely want you guys to keep joining in.
I'd like to
Great.
recognize some of the
Wow.
people who have joined in since we've been talking, and one is Isaac Turker has joined in just in the last few minutes. Also, again, like to recognize Andreas Daniel, who has unmuted himself, and maybe he can speak to us from Argentina.
Yes, yes. You listen me?
Yes, we hear you loud and clear.
Daniel? Okay, thank you very much to invite me to this conference. I work in Argentina to make the cardiac oncology that makes develop the cardiac oncology here. I pray that you give me a place in your society to do it. Well, I'm sorry, but I have another compromise to go. I can't go to Vancouver, but I believe the next time I will be there with you in other opportunity.
Perfect.
Thank you very much.
You're welcome, and I'm sure we'll come up with different things as we go along. We just want to make sure everybody knows about them. But so anyway, thanks a lot, everybody, and we really appreciate you joining in.
We have Gaetano Motala, who's logged in as well, and Lauren Dasserer, Jeffin Munley. And so I'd just like to recognize everyone who's come to the conference today and thank them for their attendance. We look forward to this meeting on the usually the second Thursday of the month at 9 o'clock Eastern Daylight Time until we change to Eastern Standard Time. And so we're glad you all can attend. We welcome Andreas as bringing in our newest chapter from Argentina, which we just conceived a couple days ago.
Okay, thank you very much. When you want, I make a conference to take a case report, a case of a patient of my hospital. If you want it, only say me. I prepare the case to go.
We're always looking for presenters, so we will keep you to that. So.
Oh, we'd like to appeal to people to sign up as the attendants for this conference and also as presenters. And so we're going to ask that you go to our website. ICOSNA, our Cardiac Care Critique, is another website where you can sign up as a presenter. So ICOSNA, our Cardiac Care Critique, or get in touch with me personally or Dan to sign up as a presenter.
All right. Well, thank you guys. I gotta head to clinic now.
All right. Thanks, Dan. Thanks, Eric.
Thanks, Dan.
I just was going to also mention we opened our Seneca study, which is for anthracycline-induced cancer survivors who have systolic dysfunction with an EF less than 40%, looking for candidates who might be willing to undergo endomyocardial stem cell injection. So I will send more information through the ICOS.
Perfect. Yeah,
Society.
Carrie, I have a patient that I saw about a week ago that might be somebody to think about for that.
That'd be wonderful. I'll send you the most recent flyer.
All right. Sounds good.
Great. Thank you.
Thank you so much. And again, we need people to sign up as presenters for this conference. Appreciate it. Thank you.
Thank you.
Thank you.
Thanks.